Our recording, and Committee Member Anderson, are you good to go with the agenda?
Yes, I got your text with the new, although it looks pretty similar to previous.
Pretty similar.
Yeah.
And we can walk you through it it just takes a little longer. It's just very similar to Robert's rules, and we can explain it to the committee if you prefer.
Well, how about I go through it, and then if anybody has questions, they can let us know. So good morning, everyone. This is Committee Member Anderson of the Public Health and Pharmacy Formulary Advisory Committee, and I now call this meeting to order. Today is Wednesday, February 21st, 2024, and the time is 9:02 a.m. The Public Health and Pharmacy Formulary Advisory Committee meetings are conducted in accordance with the Oregon Public Meetings Law. And under the Public Meetings Law, governing body meetings are open to the public except as otherwise provided by law. The presiding officer has the authority to keep order and to impose any reasonable restrictions necessary for the efficient and orderly conduct of the meeting. Governing bodies are authorized by ORS 192.660 to meet in, quote, closed or executive, end quote, session in certain limited situations. All official actions by the committee must be taken by public vote, and the vote of each member must be recorded. We will now take roll call. For the record, when I call your name, please verbally acknowledge here. I'm committee member Lorinda Anderson, and I am here. Committee member Andrew Gibler.
Present.
Committee member Catherine Hammond. Oh, she is excused. Apologies. Committee member Sean Jones. He hasn't joined yet, right? Committee member.
That's correct.
I'm not seeing Alicia either. Committee member Alicia Lee. Committee member Mark Myers.
Present.
Committee member Sarah Wickenhagen.
Present.
Staff member Jennifer Davis.
Here.
Staff member Brianna Efremoff.
Here.
Staff member Rachel Melvin.
Here. Okay, so for the record, Lorinda, if you could just state that Sean and Alicia are absent.
Sure. For the record, it looks like committee members Alicia Lee and committee members Sean Jones are absent. All right, so to just review some housekeeping and meeting etiquette, if we could have all committee members and staff silence all of their devices. When you speak, identify yourself as committee or staff member. And since we also have SMEs, you could also say SME member with your last name each time you speak. Please speak clearly and one at a time as it is critical for the public record. Please note that this meeting is being recorded and retained as a public record. Public comment, if applicable, occurs towards the end of the meeting, and the committee will not deliberate any issues or requests during public comment, such as formal requests or currently proposed protocols. All right, we will now review the meeting agenda. I believe this was sent to everybody in an email, so I am hoping to get a motion to move to approve the meeting agenda. Is there anybody that is willing to do that?
This is committee member Gibler. I motion to approve the agenda for today's meeting.
Thank you.
Committee member Myers, I second.
Great. How about committee member Wickenhagen?
I approve.
And committee member Anderson, me approves as well. I don't believe we have any others.
Yes, committee member Anderson. So as part of Robert's rules, the version that we're using, if you could also just go down and do the roll call to vote, we're still going to use the list. So everyone else needs to say yes after the second and the first. Thank you.
So even if they're not here, so committee member Jones is absent.
Oh, no, I'm sorry. You don't have to state their names for the rest of the meeting. Just skip over those two. So Gibler, Anderson, you said yes.
Myers had seconded it, and Wickenhagen just said yes. Or she approves.
Very good. So on the next set of motions, what we'll do is whoever so moves the first and then whoever seconds it, they still are we're still roll calling the vote down below. So you'll ask them, it's almost asking twice, if that makes sense.
Oh,
Not to
okay.
confuse you. Okay, thank you.
Okay, that makes sense. All right.
Okay, so the motion.
The motion has passed
Okay.
to, yes, approve the meeting agenda. And now we are going to move to approve the 9/15/2023 Public Health and Pharmacy Formulary Advisory Committee summary, meeting summary. Do I have anybody to motion?
Committee Member Myers, I move to approve.
Great. Anybody as a second?
Committee Member Gibler, I second the motion.
Great. Committee Member Anderson, I approve. Committee Member Gibler,
Aye.
Committee Member Jones, not here. Committee Member Lee, not here. Committee Member Myers,
Aye.
and Committee Member Wickenhagen.
I approve.
All right, looks like the motion passes. All right, we will now receive an update regarding the committee appointments and reappointments with staff member reappointment update. The Public Health and Pharmacy Formulary Advisory Committee has the following member opportunities available. We have one physician member position available for appointment right now, 2 pharmacist member positions available for appointment or a reappointment now, 1 advanced practice registered nurse member position available for appointment or reappointment now. And if you are qualified and interested in applying to be considered for a position as a Formulary Advisory Committee member, visit boards and commissions for application information and additional resources. All right, we will now receive a rules update from Staff Member Davis.
Staff Member Davis, this will be quick and short. At our last meeting in September, the board had already adopted new rules in Division 115 for the formulary and protocol processes. Those rules are about to become effective. They become effective on March 1st, 2024. There has not been further change because those rules have kind of been stuck in a holding pattern. They were approved by the board in August, and now they're just sitting there waiting to become effective March 1st. The only caveat to that is we did have a temporary suspend and a rule change that will happen on March 1st, just to make sure that all the vaccine protocols that you approved back in our special meeting that we had get onto that formulary and are there on March 1st. So everything will look just as it is in Division 20. It'll just be moved over under the new rule numbers in Division 115. That is all I have. Back to you, Committee Member Anderson.
Great, this is Committee Member Anderson. We will now review and discuss mailing a protocol concept for STI PEP with Staff Member Davis and subject matter experts Ian Doyle and Jeff LaRue.
Okay, I am going to open up the cover page for this document and then share my screen. So give me just a second. I'll see your faces. Okay, so I'm going to hand this over to subject matter expert Doyle to kind of talk about the submission and walk us through the document. I will drive and show you where on the screen we are talking about and make some comments along with him as he presents the protocol. So over to you, subject matter expert.
Smee Doyle speaking. Thank you very much, committee, for allowing me to speak to this proposed protocol for your review. You may have seen in the news over the last few months that the nationwide rates of syphilis are at a 70-year high. and that's compounded by the fact that there currently is a drug shortage for the preferred medication of treatment, that being the penicillin. And with regards to the benzathine penicillin G, it is not expected to come back into a regular supply until after the second quarter of this year. So in conjunction with that, there was a recent CDC guideline that had become available, or should I say a guideline that is currently receiving public input and is not yet final, but I thought it would be an opportunity for pharmacists to be able to provide doxycycline as a STI post-exposure prophylaxis, so that it could be one step in our tool belt to decrease the rates of transmission of sexually transmitted diseases, particularly syphilis, where treatments are currently limited, as stated. So with regard to the STI PrEP, this is sometimes referred to as, in other places as DoxyPEP, but we've decided to include this title as bacterial sexually transmitted infections, or STI PrEP, for the protocol. The protocol uses all the different assessment process elements that you see highlighted in yellow, and page numbers to be determined. With regards to the recommended training, I'm recommending that no additional training or education be necessary or documented. There is DoxyPEP training that is available, particularly the one called DoxyPEP Who, When, and How, which is about 1.25 hours, and would recommend that if the committee, as the question off to the side, recommends that training be required, then that would be one of the sample items that I found. With regards to your consideration, such as the HIV PEP protocol, which requires education for trauma-informed care, the DoxyPEP does not include, the DoxyPEP citation that I've included here does not include that, and so would the committee also like to require that as well. I don't work in this milieu, and so I don't know specifically, or I can't provide you a strong recommendation on yes or no with regard to that question. Resources down below are cited with regard to what resources that I've used in developing this project. I'll pause.
Any questions from committee members just on the cover page? Any comments about whether you want to see required training?
This is committee member Wickenhagen. I don't want to add any additional barriers, so I think this looks great, so appreciate it.
This is committee member Anderson. I agree. I get the feeling that if people are going to be doing this one, they've already done HIV PEP and PrEP stuff. So hopefully they've gotten that trauma-informed care. I like the idea of maybe saying that it's like one of the recommended trainings that you would list in this area, just like with the DoxyPEP and the National STD curriculum. So maybe having a separate bullet point that talks about the trauma-informed care.
Any other committee members want me to add a separate bullet for the trauma-informed care as a recommended?
This is committee member Gibler. I'm a little naive on this issue around what that education entails, but I do think it might be appropriate that there is some level of training for pharmacists if they don't have it already in recognition of child sexual abuse, since this protocol goes down to 13. And I don't know what kind of training typically employers have. I mean, I work for a university, so we have annual training on this. But I think if we're treating children, we may run into issues with pharmacists where they're encountering situations that we want them to have the tools to be able to recognize abuse or assault readily and be comfortable reporting it as mandatory reporters.
This is Smee Doyle. I will just offer that 13 years of age is the minimum age for this protocol, was derived from wanting to match the HIV, PEP, and PEP protocols, which go down to 13. And also, there is potential risk for using doxycycline, or doxypep in children and adolescents due to the potential harm on teeth. And so that's why 13 years of age was chosen.
Yeah, this is Committee Member Gibler. From a clinical standpoint, I don't have any issue with doxycycline in 13 or older. It's just what I mentioned. Again, I don't practice in this area, so I don't really have a full grasp of how comfortable pharmacists might be understanding that if they're presented with a 13-year-old.
This is Smee LaRue. Actually, I think this is actually a pretty valuable comment just in general as we're diving into this space. Something in clinic that we evaluate for quite a bit, but since we are going to bring pharmacists into this realm in the community setting, a brief training, even if it's like a one-pager of being able to look for obvious signs of sexual abuse or trafficking, I think covers due diligence. I don't think it needs to be super involved, but I do think I think that would be a valuable addition.
Staff Member Davis, I was just realizing that this bullet that I had added was really duplicative of what was already in the lead-in, and just adding to the lead-in to make sure it includes trauma-informed care. Again, this is a recommendation and not a requirement. I'm not hearing consensus for a requirement at this time. So for those on the public call, under recommended training, it would now state completion of an educational training program of at least 1 hour related to the prescribing of doxypep or STD curriculum to include trauma-informed care. Okay. Anybody have additional comments before we move to the next document, the protocol?
Smee Doyle speaking. With regard to that proposed final language, I know that the top bullet point for doxypep does not include trauma-informed care. I don't recall whether or not the national STD curriculum does or not. So it may be valuable to the pharmacist reader to have an asterisk there indicating that they might have to get that elsewhere outside of these two programs.
Okay. I've added an asterisk with a comment. Wait just a second to save this. Now we open intake form. Back to you, Smee Doyle.
Smee Doyle speaking. I'd like to take the opportunity for to acknowledge Dr. LaRue for having reviewed the protocol in anticipation for the meeting today, and so there are some additional comments that he's included on the sidebar. The intake form at the top is unchanged from what the standard is, if you will, with regard to the comment again about treating patients 13 years old or older. That is related to matching HIV as well as ensuring that don't place patients at risk for any adverse effects to their teeth. With regard to question number 2, it's intended to provide, and correct me, Staff Member Davis, if I'm providing too much detail as I'm going through this document and you wish for me to be a little bit more shorter in comments. With regards to the identification of their sexuality, I put this question in there because the recommendation from the CDC is to treat this patient population. Dr. LaRue has added additional comment that the protocol could be potentially opened up to a broader population, but I had limited it to the CDC recommendations. The CDC states no recommendation can be given at this time on the use of doxycycline PEP for cisgender women, cisgender heterosexual men, transgender men, or other queer or non-binary individuals. If this intervention is offered, it should be implemented with considerations for ancillary services detailed elsewhere. With regards to question number 3, wanted to determine with regard to, sorry, catching up on my own comment. The big question here is wanting to understand if they've already had some testing in this area done, because the protocol recommends having baseline testing done for chlamydia, gonorrhea, and syphilis. Concern in question 4 was trying to determine whether or not the patient had a resistant infection. I'll ask Dr. LaRue to comment more on that question in a moment. And if in question number 5, symptom review, trying to refer these patients to another healthcare provider if they were demonstrating symptoms, because that would be outside of the scope for a pharmacist to make a diagnosis here. Question number 6 was trying to determine whether or not antibiotics were used in the last month just trying to determine whether or not, as a cross check, whether or not there would be another way to capture a recent history of some type of infection treatment, as the patients may or may not recognize what we were asking about in questions above. Question number 8 was for your consideration with regards to having had exposure due to unwanted physical contact or sexual assault. I'm asking the PFAC if they're interested in using this question. That is also the same on the HIV, PEP, and PrEP forms. Question number 9, as alluded to committee member earlier, the likelihood of the clientele being similar for using doxypep, that they may already be on HIV, PEP, or PrEP, could be high, but we want to make sure to get the opportunity or have the opportunity to potentially recommend those therapies as well if they're currently not on them. Dr. LaRue, could you comment on your feedback with regard to your on this form?
Yeah. So, you know, and this is based on my clinical experience, and then just what I've seen in practice with my colleagues. You know, I personally haven't seen many resistant chlamydia or gonorrhea infections or syphilis infections, but like I'll use an example of a woman that we had in clinic who had secondary syphilis, and this is before the bicillin shortage, and the recommended treatment is bicillin once weekly for 3 weeks. And after the first shot, we barely got her in for the second one a week later, and then she no-showed in perpetuity for the third one. And so I guess if trying to tease it out to make it as we're asking the patients to discuss this, I guess questions along the lines of, have you ever not finished treatment for an STI and then had it come back, or something like that, so that we can then gauge, like, was this an actual, you know, treatment failure due to like lack of efficacy of the drug, or was it because the patient did not follow up? In most of those cases, I think it's that the patient didn't follow up.
This is committee member Wickenhagen. Can I ask a question? And it's been a while since I've been in this arena, but we're not going to be able to do a test of cure here. So what are your thoughts on that? Or is that we don't do that anymore?
So at least test of cure for syphilis is definitely more complicated. We like to debate this back and forth as to how titers decrease. And so, right. We still do test of cure now and then. Most of the time, so if someone comes in to our urgent care and test positive for chlamydia or gonorrhea, and we give them ceftriaxone and azithromycin, unless they return symptomatic, we do consider that curative.
Thank you for that.
Staff
Hey,
member- Sorry, staff member Davis,
sorry.
were there any language changes that you were proposing, or is it as shown on the form?
So just brief, like maybe amendment, or question on number 4. Have you ever failed to complete treatment for sexually transmitted infection?
As an additional question or a change to A?
Maybe let's in exchange for A.
The show all marked up. Sorry about that.
This is Committee Member Gibler. What does the pharmacist take any different kind of action? I'm going down to page 7, and it looks like regardless of what the patient answers, looks like we're doing the same thing. Is that to communicate to the provider this information that we're asking up in the questionnaire? Oh, okay. Oh, okay, thank you. So would that question then would down under the exceptions would also include history of, would we still be asking about treatment resistant infections, or would we be asking about failing to adhere to treatment in the past, refer to a medical provider?
I think we would be more looking at reporting that they failed to adhere to treatment. Like I said, my experience is that the lack of adherence is the #1 rate of failure. The resistant infections is it's present, but it's not common.
Smee Doyle, so going to the algorithm, rather, I think under the exceptions for question 4, it would be a change to indicating to the medical provider on the communication to physician sheet that this had been an issue before.
Do you have a specific language change you're wanting me to make?
Can you remind me what the... so I would say to copy the language off of question number 4 that had been changed. If a patient has a history of failing treatment for, then include that information upon notification of the medical provider on whatever the form name is.
So it's not a referral, it's a
Notification.
So we'll, this is Committee Member Gibler, so we'll proceed with treating the patient and then communicate it with the provider. So, okay, I agree with that. Thank you.
And then to clarify, if they do have a history of the treatment not working, should it still have the refer to medical provider?
I think the defining factor there is, did the patient complete an entire course. So like in the case of syphilis, did they for primary syphilis, did they complete 2 weeks of doxycycline and then not achieve achieve a result? So differentiating, or clarifying that the patient did complete the entire course of treatment and then the infection did not resolve. And then that would be a refer.
Okay.
Smee LaRue, are you specifically wanting doxycycline to be listed, or would that be any treatment?
I think any treatment. I think like I said, I think the defining characteristic is that they actually completed the entire course of antibiotics. If they did complete the entire course and then their infection did not resolve, then yes, I think it moves into the realm of a further evaluation by their PCP.
Okay, so for those on the phone, I've opened up this assessment treatment care pathway, and under exceptions on page 1, I have changed the question for question 4, if history of failing to complete treatment for chlamydia or gonorrhea or syphilis infection, notify medical provider using provider fax, which is another document in this packet. Question 4, if patient completed treatment for chlamydia or gonorrhea or syphilis and infection did not resolve, refer to medical provider. Okay. Going back to the intake form, we just talked about question number 4 and did some rewording. Is there any?
Oh, this is Committee Member Gibler on number 8. Going back to what's written in the HIV PEP protocol. The wording's a little bit different in the PEP protocol. It just says, was your exposure due to unwanted physical contact or sexual assault? So that I think is appropriate wording because we're talking about the latest kind of encounter in which we're treating this potential STI for.
Smee Doyle, yes, I found that it was necessary to change the verbiage slightly of some of the questions because, and it was unique in trying to develop this protocol because we are forecasting for potentially treating somebody who might have had an exposure in the last 72 hours and would be eligible for doxycycline, or it could be somebody coming to the pharmacy and just requesting it for future use, but maybe not have had a sexual encounter in the last 72 hours. And so that's why I thought that that it was more appropriate to have a larger, a more broader question as opposed to using, as we have amended here, was your exposure due to, that indicates a time-bound correlation. And if the committee prefers that it be stated as had been amended, that's fine with me. I just wanted to provide a little bit more background on the construction of the questions.
This is Committee Member Gibler. Thank you. That clarification makes it clear for me.
Does the committee have any feedback about question number 2 in making this protocol available to any person? Or do they suggest that we continue using it for those persons' characteristics identified in the proposed CDC protocol at this time?
This is Committee Member Myers. I actually was asking the same question, expanding this, and then appreciate the input that this is based on the CDC recommendation. I would stick to CDC recommendations, be my preference.
This is Committee Member Gibler. I agree, and I think as more evidence, comes out, there was that study out of Kenya that probably has some faults to it that we might see more evidence in the future that shows benefit. But till then, I think we can always update the protocol when that comes about, gets published, and the CDC updates their guidelines.
Are we ready to open up the pathway? That's where we're at. Let me get that on my screen because I already have it open. Okay. Back to you, Smead Doyle.
Smead Oil speaking. So if the patient's less than 13 years of age, we'll need to refer. Additional information is provided that doxycycline is contraindicated in persons less than 8 years of age. And if the person does not identify with the characteristics of gay, bisexual, a man having sex with men, transgender women, then that would be a stop then just following the CDC guidelines. With regard to step number 2, trying to determine who is provided the doxycycline. There are the first version of this that I had submitted to staff member Davis. She had identified that I had a lot of I guess pathways or choices that a pharmacist could make with regard to having a conversation with the patient, and she had indicated that we needed more definitive guidelines, more dichotomous, yes or no. And so I created this table to serve as such, and definitely will want to prescribe according to the CDC guidelines that somebody who has had one or more chlamydia, gonorrhea, or syphilis infections within 12 months, and also reports that they've had condomless sex, that would be our primary group, if you will, that we're going to be prescribing doxycycline for. Otherwise, the other groups are consideration, and if other certain answers from the patient indicate they're increasing risk for contraction of one of these infectious diseases, then I indicate to move ahead and prescribe the STI PEP, excuse me. If we I will continue unless I'm asked to halt. We've reviewed question number 4 now, and question number 5 again is the more information with regards to if they're showing signs and symptoms of active infection, they need to be referred for diagnosis and active treatment by a medical care provider. Question number 7 delineates that we need to that we can, if they've had condomless sexual activity reported, that's within the last 72 hours, we can indicate to the patient to go ahead and take the doxycycline as a PEP mechanism that we are prescribing and dispensing to the patient. But if they had an experience greater than 72 hours ago, it falls outside the window for the CDC guidelines, and we would want to refer them to a medical provider for appropriate medical workup I thought that this would be outside the scope of a community pharmacist because it falls outside of the CDC guidelines. Moving down the pathway, the recommendations from the CDC is to get a baseline screen for gonorrhea, syphilis, and chlamydia. But my recommendation is that we offer that or suggest that to the patient. But we can, even though it's still in the lab workup and or the patient declines the screen testing, that the benefits would outweigh the risk to prescribe the doxycycline. And again, this is based on the fact that the CDC recommendations for the baseline is quote unquote should. The committee is asked to evaluate whether or not they agree with that and would want to make baseline testing mandatory before prescribing doxypep.
Staff Member Davis, can we stop here and just see if the committee has any questions? Because I know that baseline screening was kind of something you really wanted SME LaRue here for to provide.
Thank you.
This is Committee Member Anderson. I do have sort of a question. There was a comment above in the questionnaire associated with all of the symptoms that you could see with the different STIs. And then there was the point that if they are experiencing those symptoms, that they should be referred. That being said, there was a comment that said you could have an active infection but not have those symptoms. So my question is, if we did give patients doxycycline to treat or, for post-exposure prophylaxis and they had an active infection already, is that going to start breeding resistance to the doxycycline? And so I guess that's my concern of doing this without testing to make sure that they don't actually have the active infection.
SME Doyle, yes, in the CDC guidelines, and there are comments that there is a potential risk for, or that prescribing doxycycline in this manner, they recognize that there needs to be continued evaluation whether or not this potentially would lead to resistance. So that is one of the known risks potentially for the disease. So from a global 30,000 foot aspect, I'm trying to provide an answer to your question that's been recognized. But boots on the ground, I would ask SME LaRue to offer some comments, please.
So, yeah, no, and I had a med student asking me that exact same question the other day while we were talking about this. So I traditionally have not necessarily had test results at the time that I have prescribed doxypep, but at the time I'm prescribing, I am usually ordering labs. So if we wanted to quote unquote split the difference, mitigate the risk of antibiotic resistance, but still maintain access, that there's that bullet that the patient may decline baseline testing. So the patients do what they're going to do, which is part of the reason we need the protocol. But any patient who is prescribed doxypep, I would love to see them handed a lab order so that they may have baseline STI testing. And most patients and this is once again like just my clinical experience, but most patients who are asking for doxypep are also asking for baseline testing. This is a patient population that is pretty aware of their risk factors. There are some that we identify, through when they do test reactive for a bacterial STI that we make the offer of, but then at that point we already have the baseline testing. And so most often if a patient is presenting to the pharmacy requesting doxypep, we will hand them a lab order to be tested.
So SME Doyle, we could keep the bullet point that we have on the screen here that says provide lab order for baseline screen, et cetera, and we could remove the bullet point that says patient may decline baseline screen testing. And I'm trying, I say,
I think.
Go ahead.
Oh, I'm sorry. Speed Review. I think it's important that, from due diligence and then to meet, the concern about antibiotic resistance, that it is just a standard of practice that we provide a lab order. Now, if the patient never takes that lab order to Quest or another organization and gets the labs, this happens in our medical clinic practice too. And that would not necessarily deter me from prescribing doxypep, but they may trash the order on their way out of the community pharmacy. I don't care, but I think we at least need to give them, make it a standard of practice that they walk out with the orders that they can have testing.
This is committee member Wickenhagen. For a number of years, I worked urgent care and treated STIs on a daily basis. I guess just my concern here is the follow-up of that then puts another burden on this poor pharmacist who's always already having to do a number of things. So they do test positive. Where does that lab go? What is the follow-up? Just want to put that out there.
Staff member, SME Doyle. I recall in reviewing the HIV PEP and PrEP protocols and using it as a standard or a comparator in developing this, that those responsibilities are on the pharmacist as well, if I remember correctly. And so I would suggest that if it does come back positive in the HIV protocol, it doesn't call on the pharmacist to treat, but rather refer. And so I think that the pharmacist here could be responsible for following up with the patient with regard to those lab results. And if they did turn out to be positive, then report them to healthcare provider or refer the patient to a healthcare provider.
And yes, that's exactly what it is in the PrEP protocol. And, so a couple of other things. So, syphilis, chlamydia, gonorrhea are all reportable communicable diseases. And most labs, so I know Quest, who we use, actually often reports those to county health. And so they're, often, and county health is doing partner tracing and, things like that. So I think the most important role, and I don't think it's super, we're not going to ask the community pharmacist to interpret RPR titers. We are going to ask them, is there a treponemal antibody present? Yes, refer. Is there a reactive GC? Yes, refer. And most of the, I'd have to refresh my knowledge on this, but that can also be part of the provider notification. So when we're prescribing doxypep, we're sending note to their PCP if they have one that we're doing this. Same thing. We get reactive results. It's basically put the patient's name on the form, their PCP, so-and-so has tested reactive for GC, syphilis, whatever. And then we send that off to their PCP so that we are getting them engaged in treatment.
Well, then again, assuming that they have a PCP, so just other resources available, I would say outside of the PCP as well.
Right. And so if the patient does not list a PCP, then their county health department, which would likely be reaching out to them anyways. So for a good example, like our Planned Parenthood in Eugene Springfield, if they will reach out to the patient and they do have the capability to treat, but often our county health department is also reaching out to the patient. So if they don't get treated at Planned Parenthood, Lane County will treat them.
Yeah, tracking all committee member Wickenhagen, just wanted to make sure that it's abundantly clear that who has responsibility and thanks.
To Staff Member Davis, are any language changes needed to question 3A through B based on this discussion?
Well, this is Committee Member Gibler. I think Smee Doyle had suggested deleting patient may decline baseline screen testing.
Smee Doyle, that's correct. But I got caught up thinking of what decline means. So yes, I agree that the pharmacist, after conversation, must deliver a baseline testing form to them. But I think removing decline resolves the issue that the pharmacist knows that the patient is going to decline, I guess. So, and is, so I think if we just remove that and don't speak to that point and include the, and now do we need to clarify that per se in 1 week, does the pharmacist need to contact the patient for following up on the baseline results? And I think in the last bullet point, without being too prescriptive on how they do that, I think that we're capturing that. So I don't know that I want to put in here that the pharmacist must reach out to the patient after 1 week and encourage them to get the testing done, and after 2 weeks, if you will. So I think that it really is the patient discretion, and we could include in the patient's return requesting a refill. If they never got the baseline testing results or any testing done at that point, then we could find that as a reason for exclusion from delivering or providing a refill of the doxycycline at that time if the committee thinks that's a good idea.
Does Smee LaRue have any comment on that? What Smee Doyle just said? Okay. I guess I don't, this is Committee Member Gibler. I guess I don't have a strong opinion on whether the labs need to be received before refills. I defer to others.
This is committee member Wickenhagen. I would not add that. Be my recommendation.
Committee member Myers, I'd agree. I think the point of this whole protocol is to try to decrease the rates of infection. And regardless of whether the patient's following up to get labs, they're still engaging in behavior that puts them at risk, and we're trying to reduce the spread. So I think the concern about antibiotic resistance is valid, but I think the concern about spreading syphilis outweighs that concern.
This is Smee Doyle. Shall I continue, Staff Member Davis, with comprehensive therapy assessment?
Yes, you may.
Okay. Question number 8 on the intake form is that question about having been potentially assaulted, and provides information that we are mandatory reporters as pharmacists and what action that we need to take. If they are not taking HIV PEP or HIV PrEP, then the pharmacist can offer to the patient to complete those intake forms and have those potential therapy modalities available to the patient. And additional corollary recommendations providing counsel on the risk of reducing strategies for spread of disease include the condom use every time, and also reducing the number of partners that the patient themselves is being involved with. If we move on to the next, go ahead.
Committee Member Gibler, can I touch on this a little bit? I have a recommendation for some language addition, not any changes to 3A, and just I wanted to go back to the statute and what OHA verbiage that OHA uses, and after, if you can just entertain me for a second, after this ORS chapter 419B period, a new sentence that, let me just read it off real quick what it has. Pharmacists, just to emphasize the importance of this, pharmacists must report any instance where they become aware of or have reasonable cause to believe child abuse has occurred. I would like that sentence added if there's no objection.
None from Smee Doyle.
And the other comment I had is at the very top, sexual assault survivor question. Just in some of my research yesterday, the language, they also use the language sexual assault victim or survivor, depending on sometimes how they feel about the timeline of when it happened. And if it's more recent, they usually identify as a victim, versus if they're getting therapy or seeking therapy, they consider them themselves more as a survivor. And I think we can include both here I just think sometimes language is important, and I think if we can add victim or survivor, that would be appropriate.
This is Staff Member Davis. Committee Member Gibler, did I capture your language correctly for the second sentence?
Yes, you're very good at that. Thank you.
This is Smee Doyle. Also saw a thumbs up from Smee LaRue with regard to those changes. If we move to, there seems to be a misnumbering thing that happened. We have 2 number 3s now repeating. Because of the drug side effects, the next section talks about some precautions that the pharmacist may take, and of course, doing a standard drug utilization review. The choices for drug product would be the immediate release or the delayed release product, recognizing that the delayed release product is probably less desirable because of the expense around the medication, but perhaps there's some reason that 1 unit dose item as opposed to 2 unit dose items would be preferred by a patient. The suggested fill quantity could be variable. The guidelines and practices had indicated through my research to, if you will, flex up and down depending on your interaction with the patient and trying to determine how many at-risk sexual encounters that they might have. But again, trying to be static and dichotomous in a decision, I settled on 30 doses with no refills at this time, knowing that 30 doses potentially is at minimum a 1 month supply, or potentially it could be a much longer supply in that, depending on the person's particular behavior.
Committee Doyle.
Member, yes.
Yeah, thank you. Just a little hiccup here. Medicaid only covers 14 days of doxy because acne is a non-funded condition under Medicaid. And so they have this quantity limit, day supply quantity limit in place. So something that is more static might be appropriate. Without going through the state's Pharmacy and Therapeutics Committee and getting that changed in a timely manner. But so what I'm saying, a quantity of 6, like a hard number, like a quantity of 60 or 30, depending on the formulation, you might get a rejection for Medicaid.
I can speak to that to a certain extent too. I've been doing doxypep for a little while via protocol, in our clinic, and it's rare that I write for a full 30. Usually it's like 2 weeks, because my intent is not for them to need to prophylax every day. If that's the environment they're in, then that triggers a need for risk reduction counseling in general. That's not that there aren't people who have very healthy, a lot of good mental health that don't engage in a lot of risk behavior, but my intent usually is for them to use this now and then. Most of my patients say they use 3 or 5 a month, and they're among the more active patients. And so a quantity of 14 for 28 days or 30 days to line up with the OHP guidelines might just make it expedient. And that's my 2 cents on that.
Smead Oil, I agree to changing the quantity. It was an educated guess on my part. So, committee member.
Just to be clear, is the recommendation to change it to 14 doses?
Smead Oil, yes.
Thank you.
Committee member Gibler, is it correct that for the immediate release 100 milligram caps or tabs, if the dose is 2 of them per dose,
right, that's correct.
Then 28 of those capsules or tablets will be covered?
Yeah, it'd be 14. Yeah, it'd be 14 doses again for that 14. As well.
Okay, all right.
Yeah, so 28.
Okay.
I'm just going to jump in here real quick and just say I got to sign off I'm getting summoned by my medical assistant. But please feel free to send me any other updates, and thanks for bringing me on.
Thank you for your help.
Thank you.
Thank you.
Thanks, guys.
For step 6, complete the patient encounter, providing information with regard to how to use the product appropriately. There in the CDC guidelines and in other resources, they had recommended long-term management would be including to be checking a CDC and LFTs. But I did not think that this was a strong recommendation for a pharmacist to do on a regular basis. But
Smee Doyle, this is Andrew, committee member Gibbler. Can you, just because most of my experience has been around, hasn't been around a lot of medication protocols yet, a lot of vaccine protocols, but these counseling points, would they typically be included in our protocols as part of the treatment pathway, or are they necessary? This good information, I'm not sure if this a lot of this is would be standard counseling points for this medication.
Staff member Davis. Oh, sorry. Go ahead.
No, thank you. Go.
The staff member Davis, we do typically see some level of counseling information included in the medication, the standardized assessment treatment care pathway. It's usually, sometimes it's in a table form and it will just be a section like consider going over these points. And then the committee has generally also reflected this information in any like provider facts that's received or patient information to make sure that it covers the same information.
Thank you.
Smee Doyle, when I was creating this, I was utilizing templates of the vulvovaginal candidiasis template, as well as the HIV PEP and PrEP. And so I put in here what I thought would be most appropriate without going into the weeds, so to speak, with everything that could possibly be listed.
All right, thanks, Ian.
Committee member Wickenhagen, I've done a lot of this counseling and I've never mentioned CDCs or LFTs. So I hope I'm not letting the community down, but just being honest.
Well, I suppose it's different if they're taking it frequently, chronically, versus just a 7-day course or 14-day course.
Or one Smee Doyle, or one dose every week, so to speak. So most of the drug information is not potentially relevant to those people taking the product so infrequently. So if the committee wishes to take this bullet point out, I think that's would be very appropriate.
I would recommend deleting that point there. Thank you. Committee member Wickenhagen.
This committee member Anderson, I agree with that.
And that's fine with me too, committee member Gibbler.
There are other vaccinations that would be appropriate for this patient population, and to remind patients that the doxycycline is not going to be preventing these potential infections as well. As we move into monitoring and the continuation of therapy, the CDC guidelines are to assure that we have testing every 3 to 6 months. And I look for recommendations from the committee with regard to what language they might think would be most appropriate, but I chose the shorter interval of 3 months, but allowing up to a 6 months interval. But the intent is that at a minimum every 6 months that the patient be receiving the screening for STIs, and that information is available to the pharmacists for the refilling of the doxycycline beyond at those 3 or 6 months intervals. The CDC guideline, again, is not definitive. They say screen for gonorrhea and chlamydia at anatomic sites of exposure and syphilis every 3 to 6 months.
This committee member Gibler, I don't have any, I think I agree with the language here. Only thing I was a little confused about and was the term refills, and if anyone reading the protocol would get confused by what that means, since it's not it's just a continuation of therapy, but not a refill of the original prescription, since the prescription actually has no refills on it.
Okay.
I don't know if if the Board of Pharmacy has any other recommendation. Just continuation or yeah, something like that.
Smeed Oil agrees with the change.
Thank you.
Staff Member Davis, I'm rewording what is now 7A, it was 6A on the protocol. Continuing therapy with STI PEP may be provided upon evidence of negative STI testing. And then on the last bullet, doing the same thing. If no STI is currently present, prescribe continuing therapy for STI PEP. I don't think I spelled continuing right, but it's not arguing with me. I did. Right. Moving on.
Smeed Oil, yes. And then the last page is medication considerations for relaying to the patient, and references provided where the information for the protocol had been obtained, which includes CDC, Micromedics, and other protocols from clinics in San Francisco and Detroit and other places.
Smeed Doyle, this is committee member Gibler. Just around the teeth discoloration point, since we're not treating children that young, is that necessary to include in the protocol?
Because the committee agreed with keeping the age limit at 13, I agree taking that bullet point out is appropriate.
And the dose and directions, since that's already stated elsewhere, is that also, should we repeat that as well? Isn't that listed above in the treatment pathway already?
Yeah, Smeed Oil, that again, I was modeling off of the VVC protocol, and so this mirrors the stylistic aspects of that. I agree that that's not absolutely necessary to have that here. The dose and directions restated again.
This is committee member Anderson. I was actually going to ask to kind of go back to the questionnaire later, but one of the things I wanted to bring up with that had to do with these instructions here about condomless sex, but it's also included oral sex. So I guess my question is, I was trying to go to the guidelines to find out whether or not they actually call out condomless oral sex. Because I don't know of anybody, or if that's like, I guess I've never heard of anybody doing oral sex with a condom. Maybe that happens. I just haven't heard of that. So is that in the guidelines? Like with that, and the reason I bring it up is because I went to the PEP and PrEP protocols to find out how they deal with it, and they do not actually include condomless oral sex. They actually have like a whole area in there about like oral sex with fluids is kind of what I gathered from those. So I'll pause. Is that in the guidelines, that specific verbiage?
Smead Oil, in the CDC recommendations, or at least the protocol that is open for public comment at this time, includes statements about using doxycycline in studies that where patients had condomless anal or oral sex up to 3 times per week versus no medication prophylaxis, and then with regard to conclusions, it says, based on the clinical trials, systematic reviews, and studies of populations who would likely benefit most from an intervention to reduce bacterial STIs, the following considerations are recommended. Doxycycline 200 milligrams taken orally within 72 hours of oral, vaginal, or anal sex should be considered for gay, bisexual, and other MSM, and for TGW with history of at least 1 bacterial STI in the last 12 months. So that is certainly the consideration and the recommendation in their summation box, with strength of recommendation and quality of evidence being A1, doxycycline 200 milligrams taken once orally within 72 hours of oral, vaginal, or anal sex should be considered for this patient population. And my understanding is that there can be oral transmission of STIs that create a pharyngeal infection site. Does that answer your question, Committee Member Anderson?
Yeah, and I actually did find it as you were talking in the guidelines. It's just so interesting. I think it might kind of go ahead.
Oh, I was just making a joke. I talk so much, anybody could find anything that they're looking for by the time I stop.
Yeah. No, this Committee Member Anderson, I guess I'm just kind of thinking back to what Dr. LaRue or Smee LaRue was mentioning about how, like, if this is something they need every day, then you might need to have like a further conversation. It makes me wonder if that includes having oral sex with condoms. It's just interesting. Okay.
Are we ready to look at the next document?
Do you mind if we are between documents, if we go, sorry, this is Committee Member Anderson. Do you mind if we go back to the questionnaire?
Okay.
So from what I've gathered, because I was going through, like I mentioned, the PEP and PrEP protocols, and I never actually saw that they asked that question in number 2 of, you know, how you identify sexually. And I guess I'm just concerned that wording it like this is going to just seem, what's the word I want? Stigmatizing, maybe, I don't know. Is there a way we can reword this? Because it looks like our population is really just for men who have sex with men or are transgender women. Does that sound correct? So I guess I'm wondering whether or not we could reword this to literally say that. Are you a man who has sex with men or a transgender woman?
That wouldn't a bisexual individual still be at risk?
But a bisexual individual is somebody who is having sex with a man who has sex with men. Or so I guess that's the question. Is this for homosexual women as well?
The current CDC guidelines and review indicate that there's not enough evidence to use doxycycline in other patient populations than those using these words in question 2.
I guess I'm just curious if there's a way to be more inclusive instead of just trying to call out these very, very specific ones. And I could easily see some people maybe even starting to have questions about these. I don't know. Does anybody else have thoughts on this? I guess I'm having a hard time with this verbiage.
Smee Doyle, on a previous iteration of this document that Smee LaRue had reviewed, his comment was, I'm not sure if this part is necessary. These populations are at higher risk. And he said, however, I would offer doxypep to any population at high risk for bacterial STIs.
Okay, and that's actually what I was, if we could remove that question altogether, that would be fabulous. Do we need to keep it to this population? I get that does look like the population in the guidelines.
Yeah, that's my only concern, is we're going outside the evidence at this point. And then that, this evidence is still maturing, right? So we may know more in the future how well this doxypep works in other populations, but is that something we want pharmacists to be doing when it may not benefit the patient?
Smee Doyle, for me, as I'm trying to think of community pharmacists running through an algorithm, trying to determine who is at high risk, eventually, I think if we're following the CDC draft guidance at this time, we're going to be effectively getting down to this patient population as identified in question 2. So I see it as, if you will, cutting to the chase. And there was, when we were on this topic before, I recall that committee member Myers had indicating also agreement to stick with the CDC guideline area and not expand it.
Committee member Myers, yep, that's an accurate representation of what I said. And I think, this is a guideline that we are putting out. If somebody wants to expand it individually, I think that based on a clinical circumstance, that's up to them. And I wouldn't take umbrance with that. But if we're putting out an overall guideline, I think we should stick to the CDC guidelines. I'll just
I'm not
add,
hearing-
Committee Member Myers, let's just add again, we're placing a high importance on evidence-based medicine in our practice. And I think I see that in, lots of practice around the community, and doesn't mean that sometimes we're behind the curve with that, but I think it's important to try to stick to that.
Staff Member Davis, I'm not hearing consensus to change question number 2. May I propose that we take a break? We're scheduled for a 10-minute break. It's 10:32. And then resume conversation at 10:42.
This is staff member Anderson. That would be fine with me. Or not staff, sorry, committee member.
Okay, so reconvene at 10:42. See you in 10.